Welcome to the LDN Radio Show, brought to you by the LDN Research Trust. I'm your host, Linda Elsiegood. I have an exciting lineup of guest speakers who are LDN experts in their field. We will be discussing low-dose Naltrexone and its many uses in autoimmune diseases, cancers, etc. Thank you for joining us. This show is sponsored by the Holtorf Medical Group, whose goal is to improve the quality of life for everyone they see, especially those suffering with chronic conditions. Their physicians will provide you with cutting-edge, personalised care that delivers measurable results. To learn more or book an appointment, call 1-877-508-1177 or go to holtorfmed.com, which is holtorfmed.com. Today our guest is Dr Kent Holtorf, who's the Medical Director of the Holtorf Medical Group. He's also the founder and director of the non-profit National Academy of Hypothyroidism and medical advisor to the LDN Research Trust. Dr Holtorf handpicks the finest doctors to train and represent the Holtorf Medical Group. Each doctor brings expertise to complement therapies developed by Dr Holtorf. The doctors are medically trained, MDs, DOs, NDs and NPs, and then personally trained by Dr Holtorf. It's a pleasure to have you back with us, Kent. We're really looking forward to learning about Lyme disease today.
Hi, Linda. It's always a pleasure, and thank you for having me back. It's always fun.
Thank you. And first of all, can you explain to us what Lyme disease is and how people can catch it?
Yeah, so basically, Lyme disease is the infection from Burgdorfia, a spirochete, a corkscrew-shaped bacteria. But it's very interesting, and it works very different than many infections infections. Now, the standard thought is it's basically you need to be infected from an infected tick. It is exploding in areas with no ticks. And so the newest studies are now showing that it can also be transmitted in utero, mosquitoes, fleas, bed bugs, mites, and then also the newest literature is showing that it is likely sexually transmitted as well. So, which explains why it's spreading to areas where there are not significant ticks. But ticks are also spreading like crazy, and they're being transmitted transcontinentally from birds, and then they basically have reservoirs in mice, deer, and so they're just becoming a huge problem. And the biggest problem is that the tests that people do to see if they have it or not are missing 20 to 80% of people with Lyme. So you can see why it has basically all the things that make up an epidemic, and basically this were in controversies in how how many the incidents are and how many people are infected. In fact, when we get a positive Lyme test, the California Health Department sends us a form. They ask us two questions. They say, was there a witnessed bullseye rash by a doctor? And the second question is, have they had their symptoms more than 6 months? If there was not a witness bullseye rash and the symptoms are more than 6 months, they say, oh, it's not Lyme. So you can see how it's just exploding. Doctors will say there's no Lyme in California. Well, because they say there's no such thing as chronic Lyme, which is crazy. That is the biggest epidemic. It seems like everyone that you talk to, they either know someone, they're sick, their family member's sick. So it's just a huge problem that is being way underplayed.
So, okay, it's being underplayed, but what is happening out there to help these people? Is there a plan on trying to stamp out Lyme disease, or at least treat it?
Well, it's interesting. Yeah, you look at the Infectious Disease Society of America they've dug their heels in and basically said there's no such thing as chronic Lyme, and hundreds and hundreds of studies show that's not true, and that's the problem in medicine. Things become, I love medical debates. But there's rarely does that happen anymore. It's kind of like politics. It's like there's two sides, and the one side will not, give in on anything. Doesn't matter. It's like you can show them, 50 studies, and nope, we don't like that study. And it's interesting. And I have a series called 17 Years Ahead in the Annals of Internal Medicine. Looked at what doctors know and what they're practicing. And they found that they're practicing on average 10 to 20 years behind what's available in the medical literature. Say, wow, okay, well, how could that be? One problem is they don't read medical journals. They don't. They don't have the time. It doesn't help them. They can't use these medical journals to help their patients. It's so dictated by what the insurance company says. It basically, the more you know, it's wasted. And, it's basically with the insurance model that we have now, it's doctors required to see more and more patients. So the doctors that care the least make the most. The doctors that know the least make the most. They can just run the patient through, not care. And it also goes to the kind of the psyche of the doctors. So if you have this Lyme patient or potential Lyme patient with all these crazy symptoms and say, look at them and say, well, they do a CBC and a chem panel, a lipid panel, and say, well, there's nothing there, you're fine. I don't believe that illness. By saying they don't believe it, it gets them off the hook. Where if they now believed it and they don't do anything about it, they now feel bad about themselves. Hey, I'm a bad doctor. But it really is a defense mechanism saying, hey, it's not me. I don't believe in this illness. It's the patient. But what they found was the biggest determinant of why doctors don't keep up with the medical literature. It is if you give a doctor, here's 50 studies showing that what you're doing is an optimal or correct, they will say, no, my patients are fine. I don't believe those studies. I don't want to believe those studies. So that's why what they found that it takes on average 17 years for a proven new concept treatment, basically something like, hey, Lyme disease, chronic Lyme disease, will take on average 17 years to be accepted into mainstream medicine, unless it's a new drug. Now, if it's a new drug, there's a sales force, and that's how most doctors learn is they get the couple abstracts from the drug reps and say, okay, I can use this new drug. Your study that you funded shows it's better than the one I've been using. So there, I learned something new today. And then they go to their conferences once a year in Hawaii or, Vail, and they do their skiing and show up for a couple hours, and that's it. And all the societies are, funded by drug companies. So you wonder, they get everything free. Everything from also all the studies that are published is that, it's so hard to get anything so-called alternative or integrative into a major journal, because if it says something against, that basically what is standard, you're going against their basically who's funding the whole journal, or their advertising. And you look at the journals now, it's just the covers they're covered with advertising. And every third page is, a 5-page spread on a drug. So it's just a broken machine, and it's just so many incentives for bad medicine, really, and just for biasness, and really we've kind of lost sight of that. I think what doctors go to medical school for.
So, what hope is there out there for people who have chronic Lyme disease?
Who is the what? I'm sorry.
I said, what help is there out there for those people that have chronic Lyme disease now that can't wait 17 years for a treatment to be recognised?
True. Yeah. So the nice thing is that there is help. And so when you go to these Lyme conferences, you see the memberships are just exploding. And there's a good number of doctors that are realizing, hey, this is, and they're more evidence-based than so-called standard medicine. And that's why I hate the term alternative. It sounds like, a lot of doctors think, well, it means there's no studies. But it's actually, more evidence-based than, what basically the standard guidelines are. And they also looked at, how good is the evidence of guidelines. Let's say you take anything, the Endocrine Society. They looked at their strongest recommendations were only supported with strong evidence 19% of the time. So it's interesting how it's just a big vicious cycle. But yeah, the key is to find a Lyme literate doctor. There are a number of Lyme societies out there. ILADS, ILADS is a International Lyme and Associated Diseases. There's like whatever state you're in. There's the California Lyme Disease Association, and there's just getting a lot of these organizations popping up because people's lives are just devastated. And, it's kind of fortunate. I don't know if that's the right word, but say that celebrities are getting sick, and that's the way our world works, right? But that's where it gets attention. So, people are realizing that this is a true thing. Now, the thing is with Lyme is that when most people don't remember getting a tick bite, they say a bullseye rash that, basically occurs in less than 20% of people. They'll have like a little cold or flu symptoms or maybe nothing, especially if it's sexually transmitted. It stays dormant for years. And then all of a sudden, if they have a stressful event, stress seems to be a major thing that suppresses the immune system and allows the Lyme to now take off. So you start getting symptoms can be fatigue, depression, bipolar, even psychosis, certainly chronic fatigue syndrome, fibromyalgia, autoimmune disease, migraines. It's just, you name it. And there's so many things. So they usually will get misdiagnosed for 10 to 20 years or never get diagnosed. And then only if they get a significant downturn where they have like, oh my gosh, something's going on, where they have multiple symptoms. And we find, the weirder the symptoms, the more likely it is Lyme. And when I say Lyme, I'm kind of throwing in a number of infections, because if you look at, let's say, a tick bite, it's like a dirty needle. And you just get so many different things. We're finding sometimes babesia, which is like, it's a parasite. It's like malaria. And we're actually doing a pilot study, and we're finding a lot of people, it's causing obesity. You'll see also hypertension and diabetes. And there's some good evidence that a lot of obesity is infectious. And we're, especially if you have metabolic syndrome with hypertension, basically weight gain, you'll find they have low thyroid, can get associated night sweats, and we're finding that they're babesia positive, and you get rid of the infection, and their insulin resistance goes away, and they basically start losing weight. So it's crazy. You look at almost every autoimmune disease, the studies are overwhelmingly show that there's a chronic infection that's driving it. So the big thing is this Th1, Th2, that normally they're balanced. So Th1 gets stuff inside the cell, Th2 gets stuff outside the cell. Usually they're balanced. Now, so many illnesses will actually drive up the Th2, which is inflammation, but it's a teeter-totter, and Th1 goes down. So, for instance, if you get Lyme, you get exposed to Lyme, let's say it's a tick or some other method, it basically, you get infected, it's in your body, and it starts secreting cytokines which suppress the Th1 that would kill it intracellularly. So it lasts long enough, but as soon as then it goes intracellularly, now the body can't kill it. Now you have chronic Lyme. And that can occur anywhere from days or weeks or months after the initial infection. And once you get that, it's basically your body can't clear the infection. and it goes into multiple different forms. It basically, a standard form is a corkscrew form with a cell wall. And then when it goes intracellular, it basically doesn't have a cell wall. So now the antibiotics that helped when it was outside the cell, now it needs a totally different set of antibiotics because it's a different type of organism. It's instead of a cell wall, you need the antibiotics get non-cell walled organisms. Then it does another thing, goes into a cystic form or a round body. And actually a study just came out last week looking at the round bodies. They're very metabolically inactive, but they cause dramatically more inflammation than the spirochete. So it's all of a sudden you've had this, you got a tick bite, get sick, don't notice. Years later, where it starts forming these cysts, you start getting more inflammation, you start getting sicker, start getting these strange symptoms, a lot of neurologic, memory loss, fatigue, muscle pain, fibromyalgia, chronic fatigue syndrome, depression. And then you go to treat it, and you need different antibiotics for each different form. But then what it does also, it sends off persister cells, which are cells that are metabolically inactive. They're just like suspended animation. And generally, antibiotics only kill the growing organisms. So now it's basically resistant to almost every antibiotic. And so you can give 20 antibiotics at 10 times a dose, stop it, and this comes right back. So it's a very tough organism to treat. It's very tough to diagnose because what it does, it evades the immune system by, again, changing different forms. It has surface antigens that it shifts, so the body, basically keeps is not able to keep identifying and go after it. It suppresses what's called dendritic cells, which basically will see an organism and tell the rest of the body to go kill it, so there's no concerted effort. So it's a very smart bug, and it has more genes than any other bacteria, so it just has so many different ways to evade the immune system. Now, the problem is, as long as you have it, the more it suppresses that Th1. So your immune system's terrible in terms of killing intracellular infections. It'll also increase your risk for cancer. But your Th2 is very high, so your other immune system is going in overdrive. So patients may not even get sick a lot, or they can because of low Th1. But you'll hear a lot of autoimmune patients like, I never get a cold or anything because the one part of the immune system is too high. And so we'll use a lot of immune modulators, and sometimes they'll be known as immune booster. Like, well, I have autoimmune disease. Why would you give me an immune booster? But again, it's if you raise Th1, you lower Th2. So that's really the goal with this illness is immune modulation. We find with chronic Lyme, antibiotics, they have a part, they do, but you need something else because if the body's immune system can't take over, you're never going to clear the infection.
Well, we'll just stop you there for a minute.
Really,
We'll just have a quick break and we'll be back in just a minute. The LDN Research Trust has its own forum, which can be found forum.ldnresearchtrust.org or via our website. The forum is divided into sections, so it's easy to navigate and find what you're looking for. You can share your experience, ask questions, keep a journal, etc. Unlike Facebook, the posts are always easy to find and don't get buried. We have a private medical professionals only section. To find out more, please email me, linda@ldnrt.org. This show is sponsored by the Holtorf Medical Group, whose goal is to improve the quality of life for everyone they see, especially those suffering with chronic conditions. Their physicians will provide you with cutting-edge, personalised care that delivers measurable results. To learn more or book an appointment, call 1-877-508-1177 or go to holtorfmed.com, which is holtorfmed.com. Thank you. Welcome back. So we've got Lyme disease there. We understand more of what Lyme disease is. And you were saying, antibiotics have a place. But my understanding is if you've had Lyme disease for a long time and it's gone to chronic Lyme, as you were explaining, do antibiotics still have a place?
And let's talk about early Lyme even. So when, certainly the earlier you catch it, the better. And there is more awareness of, hey, with Lyme disease in terms of ticks, especially in endemic areas. But you look at what the guidelines are if someone gets a tick bite, and they're anywhere from give a single dose of doxycycline to 3 weeks of antibiotics. But if you look at the studies, and there's a review article that looked at 10 different studies of standard treatment for acute Lyme. So you go in, you get a tick bite, let's say you have a bullseye rash, you got the joint aches, joint pain, fever. Doctor says, okay, you got Lyme. We'll give you a single dose of doxycycline, and they say 3 weeks of an antibiotic. They found that 20 to 60% of people will never be the same after that. So, the fact that they'll be told, oh, we've caught it early, it's no problem, but you need much more aggressive treatment early on if you are fortunate enough to catch it. But that single antibiotic use for a short period of time does not cut it. It is, it's a devastating illness to have long term, and to just treat it with, the single antibiotic, which is, again, the Infectious Disease Society guidelines, is terrible. It's basically giving people the more likely to have significant disability after that. So it's terrible. You need to really find a Lyme literate doctor who's going to treat that aggressively. But once it gets set into your system, now it has all those different forms. And also what they're finding is like the single antibiotic will do, it will just drive it into the tissues and into that cystic form. So now, your symptoms are gone for a period of time, but you've just made it much harder to kill, and it's going to come back at some point, especially as if there's a stressful event, such as a divorce, an accident, birth of a baby, death in the family, any other illness, that's when it comes out. That's why it gets confused with other things that, oh, it's associated with this, or, oh, you're just stressed out, you're just depressed, because it occurs with something else. But I do think antibiotics have a place, but you do need aggressive antibiotic therapy, but alone they are unlikely to be able to eradicate the infection. And so we're finding immune modulatory treatments, such as low-dose naltrexone, are very important to be able to basically get rid of the infection. So you've got to raise that Th1, lower that Th2, and LDN is a great treatment for that because it's so safe. And now we're also finding we're doing it before we even test, because with the low immunity, what happens with the low Th1, you actually don't produce antibodies, the IgG antibodies, very well. The body can't shift from the IgM antibodies typically go up first, and then after a few weeks or so, your body starts secreting IgG antibodies. Now, the IgG antibodies are much more effective. They actually when they attach to the organism, they stimulate a thing called complement, which basically causes the infection to explode. Now, the IgM just kind of sticks to it and hangs on, kind of think of like a dog on biting your pant leg and just kind of towing along, and it doesn't kill it. So if you look at Lyme patients, they'll often test positive more likely for IgM, even though they've had it for a long time. And doctors say, oh, that shows that it's a false positive. Absolutely not. It shows that you have basically this immune dysfunction, and your body's incapable of converting IgM to IgG, or I'm saying capable but less likely of some IgG, but a lot of IgM. Now, if you give sometimes even antibiotics to kind of knock it down, your body will be able to switch over. Or if you give LDN or other immune modulating therapies, peptides, even ozone, transfer factors, natural things, probiotics can even help. Glutathione, actually with glutathione, we'll do glutathione IVs. How they'll actually induce in experimental modes, how to induce an animal or whatever it may be, or even a human, into that Th2 dominant low Th1 as they deplete the body of glutathione. So there are a lot of methods to modulate the immune system, which is key. And there are ones that people, this is great for Lyme. They don't know why, but that's actually why they work. But we really like LDN, certainly is the go-to drug and try because of the safety, the cost, and other treatments do work as well, but they tend to get more potential side effects, cost issues, but really modulating the immune system is the key to beating this illness.
And the question we're always being asked is, what can the person with Lyme disease do to help themselves? Is there anything that they can do to help improve their condition? So
are you asking about people who know they have Lyme, or?
Yes, people that have been diagnosed.
Gotcha. So, the vast majority have not. And so the key is to go to a Lyme literate physician. You can look at, again, the organizations and look at the list of members. You can look online and search Lyme disease doctor, and you'll probably come up with some. And so the number one thing is to get diagnosed. And I would not do a Lyme test unless you do, again, antibiotics beforehand, low-dose naltrexone, something, because your immune system's so low, and the typical tests are looking at your body's response to the Lyme. And it basically hides. So you want to do some things to make it so the body can see it. So the antibiotics initially will kill some of it, so now it can't hide and the body can see it, or immune modulating treatments such as low-dose naltrexone. And then, so other people that have it, usually they've been to numerous doctors and specialists with, countless different diagnoses, whether it's depression, migraines, chronic fatigue syndrome, fibromyalgia. And that's the problem. So you look at chronic fatigue syndrome as a diagnosis based on symptoms. So, but and the problem with that diagnosis is, now people say, it's a ridiculous diagnosis, it's fake. I agree with that sense, but we can pick out a chronic fatigue syndrome, fibromyalgia, Lyme patient on blood work, and basically with pretty good accuracy say whether or not they have it without even checking for Lyme or anything else, and how severe are the symptoms. So people saying that, it's a made-up illness, how can we pick it out on the blood test? But you need to find a Lyme literate doctor that does basically multi-system treatment, because that is the big problem with this illness. It affects every system, and it becomes a vicious cycle where, basically you have immune dysfunction, and you get pituitary dysfunction, which causes low hormones, and you get mitochondrial dysfunction, which are the energy for the cells. So all the basically cells that need the most energy are dysfunctional, which includes all the nerves, the brain, the pituitary. So you get lower hormones, which then causes more pituitary dysfunction. Then you add, with that Th1, Th2 shift, we find people become very sensitive to things they hadn't been in the past, where they have many side effects. They can't tolerate things. They get allergies to things that they never had. You get a sleep disorder, which again lowers pituitary function, lowers the hormones. You get gastrointestinal dysfunction because of the mitochondrial dysfunction and all the nerve problems. So basically the gut just becomes very sluggish, so they get diagnosed with SIBO. And it just goes around and around and around. So you have to intervene on many different levels and fix those problems to really be able to get back to functioning. And it becomes chicken or the egg, where it's like, well, what caused what? But so you have to fix a number of these different areas so the body can actually start being able to heal. But for instance, if the immune system's low, you're never going to eradicate the infection. You don't get sleep. You're not going to heal. And so you really need a doctor who's good in these multi-systems. And the problem with medicine is becoming more compartmentalized. So it's like, okay, you go to this specialist for your gut. You go to this specialist. You go to the neurologist. You go to the endocrinologist. You go to the immunologist, and it just around and around and around. And they just look at the one little part, but it is all connected. And again, the more symptoms you have in these different areas, the more likely you have Lyme. And so chronic fatigue syndrome, fibromyalgia, we're finding it's Lyme until proven otherwise. And the problem with those diagnoses are chronic fatigue syndrome is based on symptoms. So doctors, you got that. Here's your, we have a diagnosis. So take your antidepressants and your sleep meds and your muscle relaxants, and, I'll see you in 6 months. But it kind of gives them a license to not look any deeper. There's something causing it, but they don't want to take the time to basically figure that out. Then you've got fibromyalgia, which is based on signs. So it's basically pushing on the tender points, and if you hurt, then you have fibromyalgia. There's nothing special about those tender points. It's kind of another ridiculous diagnosis, and certainly people with fibromyalgia with everything else, but then it gives again the doctor the license to not do anything else and say, oh, he's a fibromyalgia person. Here's some Effexor or Lyrica, which you look at the studies, the difference between how effective they are, it's like just a few percent over placebo. It helps like 27% of people, and placebo helps 20%. Plus, you get weight gain and all these problems. So all these things, meds that are approved for these conditions, are just very unsatisfactory. And then you got Lyme, which is basic diagnosis of underlying. And we'll find people with Lyme also have co-infections, especially the sickest ones, Babesia, Bartonella. They also will get chronic Epstein-Barr, HHV6. They'll have a ton of things because they're low immunity. Is it the fact that you got all these separate infections? No, it's that your body just can't suppress them. So it's kind of like, when you get the chicken pox, you say, I had the chicken pox, I'm over it. But what happens when your immune system drops? You get shingles. So, and that's the key, is you have to get the immune system working in order to fix this illness.
And so many people have told me when they are trying to get a diagnosis for Lyme and they're explaining to doctors all their different symptoms, to then be told it's all in their mind. All you need, you're depressed. All these symptoms you've told me are because you are depressed. There is really nothing wrong with you. And that is so demoralizing, to think that you have made up these
it's
symptoms.
Horrible.
Mm.
Yeah. And we're finding too that, the less a doctor knows, the more adamant they are they're right. And again, it goes into the fact that they don't even know where to start to try to figure out what's going on. They don't have the time. So it's basically easier for them to say, oh, you're just making it up, go to a psychiatrist. And it's horrible. In fact, people will just cry on, the first visit that we actually believe them and listen. And then when we show them on the blood work, people say, well, what if you don't find anything? I mean, it's never happened. If you know where to look, you can't believe how many things are abnormal, and the doctor said there's nothing wrong. Yeah, when you do a CBC, a chem panel, and a cholesterol level, that's basically what they do, and they go, oh, it looks fine. Yeah, of course it is. And they try to give you Lipitor or whatever, a statin to fix your cholesterol, which then lowers your mitochondrial function more. But so, no, it is horrible. And the way people are treated, or if they have to go to the emergency room, they're just immediately labeled drug seekers. And they are treated just so inhumanely. It's incredible. And I want to mention one thing about, people on narcotics. Can they take low-dose naltrexone? So if you look at the studies, actually, it's probably not good to take low dose, but ultra low dose actually will, we have this big opiate problem now. It will actually reduce your tolerance. So, and tachyphylaxis, which means when let's say you take an opiate and you start getting used to it, and so you go up and up and up on the dose. And that's how these people that, let's say the person gets a back injury, doctor gives them Vicodin or oxycodone, and they start taking it more and more and more. Now they build tolerance, and now they're basically tolerant. They become addicted. But if you take naltrexone at much lower dose, it actually improves the pain relief. So you get more pain relief. It reduces significantly the tolerance, the tachyphylaxis, the addiction. And they're also finding when you go off of it, it reduces the withdrawal. So we put basically anyone on narcotics, we'll put them on naltrexone. Usually, and it's interesting, the studies are looks at 0.002 milligrams. Some other studies show maybe up to 1 milligram, but in general, lower is better. And you also, you need to be careful if you're on something like a fentanyl patch or something very heavy duty that's chronically, that you're not ever off of it, because you'll get down regulation of the receptors, and that little bit of naltrexone can precipitate a withdrawal, which you don't want to do. But you can start naltrexone with people that are on intermittent opiates, or anytime you're newly starting a patient. 0.002 you'll get much better results with pain. You'll be able to get off the opiates much quicker and easier, and you'll much lower risk for tolerance and addiction, and even overdose. It will block, some of the risk of even overdose. So it has a lot of new places, and really, you can't believe why that isn't part of all the opiates now. They did try to bring a combination naltrexone opiate out, but they did it at way too high of a dose, where they were combining with the dose of narcotic anywhere from 1 to 8 milligrams. Mm-hmm. So, Linda, how that is, where, more is not better, and they just went too high, so they had a lot of dropouts. And they didn't. They had problems going through phase 3, but they don't get it, So, but it really, I think anyone treating chronic pain should be giving their patients, compounded naltrexone, starting at 0.002, or maybe a little higher dose, and some people maybe a little better, but extremely safe. And I think we've been doing it on all our patients, and they've been actually able to get off narcotics quicker, better pain relief. So we find that it's a good addition.
And how long do you have the patients on such an ultra low dose for, or does that vary?
Yeah, as long as they need the narcotic. Mm-hmm. So, but it allows you actually to use lower doses, because it is more effective. So it seems the problem with opiates is, especially over time, chronic opioid use will increase the glial, the neuron inflammation. So they can actually get hypergeusia, where they're much more sensitive to pain. It's like you'll see, I don't know, when I worked in the emergency room as an intern, I remember where you get the heroin addicts, and, oh, my gosh, starting IV, they'd just be screaming. You're like, what the heck? And that's what happened. They are actually so sensitive to pain, even though they're on massive doses of opiates. Mm. So a little bit of naltrexone, basically stops that from happening.
Wow, that's amazing. Well, we'll just have one more quick break. We'll be back in just a moment. To listen to individual radio shows and interviews, go to www.mixcloud.com/LDNRT. I'll repeat that. It's www.mixcloud.com/LDNRT. This show is sponsored by the Holtorf Medical Group, whose goal is to improve the quality of life for everyone they see, especially those suffering with chronic conditions. Their physicians will provide you with cutting-edge, personalised care that delivers measurable results. To learn more or book an appointment, call 1-877-508-1177 or go to holtorfmed.com, which is HOLTORFMED.com. Welcome back. Goodness, the time is going so quickly. What I wanted to ask you, if a patient comes to you who thinks they have Lyme, what are the steps you take to diagnose and treat?
Yeah, the first thing is listen to them, right? And we have them fill out an extensive questionnaire, and you find that, they have so many issues which they may not even bring up because they've had it forever and there's so many things that are worse. But, and even with just the symptom assessment, we call it, we can usually pick them out very quickly. But so we'll basically look at the symptoms. We usually have a good idea if they have Lyme or not. Then we'll do basically a large panel, which includes immune testing. But we really want to test everything because, again, this affects all the systems. So, basically all Lyme patients are low thyroid, although their TSH is normal because they have significant hypothalamic pituitary dysfunction. So normally, doctors are taught that testing thyroid's very easy, that the pituitary secretes thyroid-stimulating hormone, which tells us thyroid to secrete T4, which then converts to T3. Levels drop, the pituitary should sense that and raise TSH. But with any chronic illness, especially Lyme, or even autoimmune disease, even just fasting, the pituitary is suppressed. The TSH does not go up. So people with low thyroid have a normal TSH. So they often need thyroid is one thing. And we'll often treat them for not necessarily for the Lyme right away because you want to get the body optimally working to have the best chance to basically for long-term success. So look at the hormones, get them sleeping. Sleeping is key. If you don't sleep, they're not going to get better. So you have to get, deep sleep. And the problem is a lot of the sleep meds is they don't change sleep architecture. So a lot of these patients don't go into deep wave stage 3-4 sleep. So there are a few meds that can help. One is Xyrem, can be life-changing for patients. So we work on these different areas. We look at coagulation defects. So what we find is that, especially with Babesia, but Lyme, other infections can do it as well, is the body will try to wall off the infection by laying down fibrin. It's not a blood clot, but it lays down fibrin. So now that's good in the short run where it's kind of keeping the infection at bay, but now the infection can hide in there. And also oxygen now that used to take 2 seconds to diffuse into the cells can now take up to 2 minutes. So you find your cells are starving for oxygen. So you get the muscle pain, the brain fog, and vascular enzymes to clean that up, or actually very low dose heparin, which is safer than aspirin. But to make that diagnosis, is you look at what I can do is we have a lab slip on our site that you can actually download I'm not sure if we have the one for Lyme chronic fatigue syndrome, but I think so. If not, we'll make sure it's up. And it shows all the tests. And what we like to do is get as much information up front as we can. For instance, there's a marker for Babesia called eosinophilic cation protein, ECP, and it goes up with parasitic infections. And so we check that now, usually it's high normal, but if you treat with something that kills the parasites and the body can sense it, it goes way up. So that's a good marker for Babesia. We look at the natural killer cell function. We'll look at the Th2 level, which we used to check C4A, but now Quest said they can't get dry eyes for some reason. But so you want to look at human transforming growth factor beta. That's a long thing to remember. But so we really look at all these different areas: adrenal function, all the hormones, the coagulation defect, the immune system, and you'll find so many defects. So we try to fix those things first before we start even going after the Lyme. And then for the Lyme testing, we don't really even bother with the standard Quest or LabCorp Western blot. They just miss, 90%. Now, if you do get that test done, if we've had it done in the past, the doctor says you're negative, but if you have a 41 kilodalton band, which is the most common band to come up, so the Western blots look at different parts of antibodies that your body's attacking different parts of the Lyme. Now, the 41 kilodalton band is the flagellum. It's the tail of the Lyme. Now, let's say, that's a false positive because other things have the tail as well. But in Western countries, unless you're, basically terrible, sewage problems or terrible gum disease, you shouldn't have that. So if you have a 41 kilodalton band, we have found that overwhelming majority of people have Lyme. Now, to do more specific tests, you can do IGeneX, Western blot, MDL has one, and there's some new ones coming out. But for all those, you want to do what's called a provocative test. You want to treat with antibiotics, usually for a week, wait another 2 weeks, and then test, and then you'll find it much more sensitive because the body can see it. Or what we'll do is we'll actually do some of the immune modulating therapies, so then now your body actually has an immune system that's helped, so it can produce antibodies and you have a better, more sensitive test. Or if you can do the Lyme culture, now that you don't want to be on any antibiotics, so if we can, we'll on the first visit do the Lyme culture and then give the antibiotics either for 1 to 3 weeks, which covers Lyme and Babesia as well, and then check those labs 3 weeks later. And you'll find you'll pick up so many more patients that were previously negative, where they thought they had Lyme, and even, very good doctors, if they don't do that, the test often becomes indeterminate or negative, and all of a sudden now it's positive. So it's very helpful to do those things to help get the diagnosis. Now, Lyme is actually a clinical diagnosis, but what I tell patients is the more sure we are of the diagnosis, the more aggressive we can be. So that's why we like to get a lot of information up front so we can find out exactly what's going on. If we have also more proof actually for the patient, for other doctors, for their friends and everyone. So when they say, you're just faking it, yeah, look at this. And you look at their labs, you can't believe how many abnormalities they were when no one checked those things before. So it's really knowing what to check, and I find the more information, the better. And I like patients to give me every lab you've ever had, bring in everything. We can go through it usually very quickly because they usually get the same thing over and over and over. But so the key is information, and then you could put together a custom plan for that patient.
So is it just blood tests and asking symptoms, that there is no other test like an MRI or a scan or anything along those lines. It's just blood tests.
Yeah, I mean, there's, you can also do saliva testing, you can do stool testing, there's so many other means, and then scans. I would love to get scans, and so in terms of scans, I love to get scans and get that information. MRIs tend not to be very sensitive, although they can show abnormalities. They'll often say nonspecific white and gray matter changes. Some of the more functional scans, SPECT scans, and things such as that are actually much more useful. But we're just finding that we can't get them covered, and so it's just been difficult. But I'd love to have that information.
Mm. Well, it's been truly enlightening. I've learnt so much about Lyme disease, and I'm sure other people will have as well. I have to say, you're one of the speakers or the interviewees in the Lyme disease documentary, which has now been completed and it's now being edited. So that's something really exciting. And of course, you're one of the speakers at the conference, and you're going to be talking on Lyme disease. So yeah, I know. But what is really interesting, and I've said this so many times, doctors absolutely loved the Q&A sessions. They enjoyed the presentations, of course, but to actually get the chance to ask a panel that have been using LDN for a long time is a real big deal. And of course, not only the people who are there on the day that can ask the questions, but those people who are watching all around the world live streamed, they get the chance to submit their questions as well. So, anybody out there listening who's going to listen to Dr. Kent Holtorf talk about Lyme disease at the conference, if you have any questions, then is your chance to actually put them to the man himself to get the answer straight from the horse's mouth, should we say.
Yeah, and I love, that's my favorite part of the conference, and I think and I agree, where most people get the best information, because it gives you, sense of real life issues and that, problems that come up, and just basically get direct answers that you would have to try to figure out, usually with talks are kind of theory and basis, but in reality, how do you do this? And I find, that people find those to be the most useful and interesting. And I find that's my most enjoyable part, which I really love doing. So I really love the fact that you have that as a large part of your conference. So, I think it's great for everyone. I think it's great for patients and doctors as well.
We have one doctor, and she said that she enjoyed the Q&As and that we answered all her questions. We asked questions which she would have asked if she'd thought of them. And what made the whole thing real for her is that when the panel didn't know a question, they weren't afraid to say, I don't know the answer to that one. So she said it made it so believable that the questions that had answers were factual answers, because nobody was afraid to say, I don't know. So I thought that was a really good comment.
Yeah, it's true.
But
it's true. And that's like when patients come back from their primary care, and my primary care said he didn't know. I'm like, great, keep that doctor. Because the other ones that it's a big ego thing, and are the ones that tell patients to stop Googling, right? It's because they can't defend their treatments. I tell patients, go on the internet, there's great information. Yeah, there's some misinformation, but bring it in. Bring all the questions in. We'll talk about it. So, I think that's, again, a great part and a great feature of the conference.
Yes. And the good thing is, obviously, it's not physically possible for everybody to travel to the conference, but for us to be able to get the conference to everybody who's got fast internet, regardless where they live, can watch it, at a time to suit them. It's available for a whole year. It's just amazing. There is so much to learn. And we're just so grateful for people as in the doctors who are the speakers, who pay their own expenses, all their own travel, without such generous doctors like yourself who are prepared to pay to be there and give up your own time. It's amazing. So thank you very much for that.
Oh, no, it's my pleasure. And you just do such an amazing job for not getting a salary and just giving such vital information and passionate about, LDN and how many people it's helping. So my blessings go to you and thank you.
Thank you very much. The LDN 2017 conference will be held in Portland, Oregon in the US, 22nd to the 24th of September. If you are unable to attend in person, we'll bring the conference to you, regardless where you live. You can participate via our live stream. Check out www.ldn2017.com for early bird discounts. The conference will examine life-changing breakthroughs for treating multiple sclerosis, Crohn's disease, colitis, autism, irritable bowel syndrome, lupus, fibromyalgia, rheumatoid arthritis, chronic pain, mental health issues, restless leg syndrome, and many other conditions using low-dose Naltrexone. For tickets, live stream, and sponsorship opportunities, go to www.ldn2017.com. This show is sponsored by the Holtorf Medical Group, whose goal is to improve the quality of life for everyone they see, especially those suffering with chronic conditions. Their physicians will provide you with cutting-edge, personalised care that delivers measurable results. To learn more or book an appointment, call 1-877-508-1177 or go to holtorfmed.com, which is HOLTORFMED.com. Any questions or comments you may have, please email me, Linda, Linda, at ldnrt.org. I look forward to hearing from you. Thank you for joining us today. We really appreciated your company. Until next time, stay safe and keep well.